Good morning, everybody. Happy, what day is it? Thursday. If you don't know me, my name is Amanda. I am a clinical nurse specialist in the NICU, and I've been a NICU nurse since 2009. I am so excited to be here today and to tell you guys about, just to talk about some test taking tips for specifically the RNC-NIC, studying tips, managing anxiety tips, all those kinds of April, May. Awesome. So a lot of you guys have scheduled already. Have any of you guys not quite scheduled yet? Or still learning, waiting to register until the promotion? Yes, I would definitely recommend that. If you haven't registered already, I'll get to that. But yeah, I would. Waiting until after April 8th, same waiting. Okay, cool, great. So hopefully a lot of this, for some of you guys that are already ready to test, you probably know a little bit about the RNC-NIC, but hopefully some of these topics will be helpful for everybody. Oops, I went the wrong way. So the agenda, we're going to review the exam format for the RNC-NIC. We're going to talk about some study strategies to help you pass, talk about some key concepts, and then also learn about some available resources to help you in your journey. So one of my first biggest recommendations always, and if you're going to get certified, whether it's the RNC-NIC, that CCRN, anything that it is, go and review the candidate guide. It's really important. There's a lot of very important information there, from the fees, the how long the test is, what the type of, what if you'd have multiple choice questions or whatever. I made a mistake with one of my certifications that I submitted my application so fast, I didn't realize I submitted an expired license, and to go back and to edit it, there's a fee for that. So really just look at all of those things really closely when you are registering. And then I like to always mention the RNC-NIC is not intended to test you at like an NNP level or a doctor level. You don't have to know every little teeny tiny thing. It wants to measure the nurse in the NICU with a minimum of 2 years experience, who has that experience caring for critically ill babies and their families. So that's what it's looking for. It's not asking you to be the highest expert in the room, but it's asking you to have that specialty knowledge of neonatal intensive care. I think a lot of us always feel like, oh, I don't know enough to register. And I would challenge that and tell you, I bet you do, but you just have to think about it in the context that they might ask in a question. So we're going to get to practice that later today. Some quick things about the exam. It's 175 test questions, but only 150 of them are scored. 25 of them they're testing their questions. So they're seeing how those questions do. They're kind of feeling them out. So I heard a horror story once of somebody who only did 150 questions. You have to do all 175 questions, because it's not just the last 25 that are being tested. They're scattered throughout. So go through and do all of those questions, but no 150 are scored. All of the questions are created with a premise or a stem and 3 alternative answers. And those 3 answers, I find a lot of people don't know that they're always in alphabetical order. So if you're going through and you're doing your tests and you see that, oh my gosh, the last 5 have all been B or C or whatever, it's fine. They do that on purpose to randomize it. The other thing about these exams is the way they create them. They use logic that looks at hard questions, and it kind of gives it more points. And easier questions have a little bit less points. Basically, what that means is that you get points for all of the answers you get right, and answers you get wrong are not counted against you. So that's how they kind of make these certification exams, and same with the NCLEX, so that they can test you on that knowledge and application of knowledge and not count wrong answers against you, if that makes sense. So what is the content? The vast majority of the content is on general management, which is our resuscitation and stabilization. So really knowing NRP, fluids and electrolytes, glucose homeostasis, nutrition, feeding, oxygen management, acid-base ventilation, Thermoregulation is huge. So all of that falls under general management. And then the next biggest section is the assessment and management of pathological states. So that's how we get into our neuro diagnoses, our respiratory diagnoses, cardiac, et cetera. And then the smaller parts of the exam, general assessment, so your nursing assessment of that baby, and then psychosocial support, how we're supporting the family, how we're preparing for them for discharge, and our professional issues, our ethics, how we have our scope of practice, the ANA scopes and standards of practice, things like that. Okay. And feel free, like I said, if you have questions, put them in the chat, but I'm just going through the exam itself really quick. I think the statistics are interesting to see how many people have taken and how many people have passed the exam. So in 2022, almost 2,000 people took the RNC-NIC and 79% passed. And in 2023, a lot less, just over 1,000 took and 77% passed. So I feel like right now, for a lot of us, the biggest barrier, the biggest mental block is that fear of not passing. And so now is really, if you were thinking about getting certified, it's the perfect time since the NCC is doing their promotion for second chance free. Now, like you guys were saying in the chat, make sure that you register in this time frame between April 15th and July 15th so that you are within that second chance free if you've not already registered, okay? I hear some feedback, so just make sure that you are muted, or actually I'm going to mute you. There we go. But feel free if you do have a question to unmute and ask. Okay, so how do you prepare? What do you do? So my recommendations, create a schedule. So you want to make sure that maybe if you're working 3 night shifts in a row, maybe that's not the best time to study, or maybe it is. When I was taking my RNC-NIC, our census was really low. It had kind of a lull. And so I brought one of those question books to work with me, and I did questions in between my rounds. You can also set up a time for yourself. Maybe you work Monday, Tuesday, Wednesday every week, or Friday, Saturday, Sunday, whatever it might be, and you're going to study every day on Tuesday. One great tip that I had learned from a professor when I was in school was study at the same time that you're going to be taking your test. So if you're always studying and practicing questions at midnight, but you're going to be testing at 9 o'clock in the morning, your brain is going to be like, I'm supposed to be sleeping right now, not taking tests. So try and at least get into that habit a little bit, maybe not every single time you study, but as much as possible. That way your brain is kind of in that test taking mode at that time. You're setting yourself up for that success. Another big thing is you want to use active learning strategies, not passive learning strategies. So listening to lecture is a passive learning strategy, and you only actually retain about 10% of what you hear when you listen to lectures. When you do more active strategies, one of the most popular ones is probably those practice test questions, right? So you're going through and you're quizzing yourself on what is this question about. Another really great active learning strategy is teaching somebody else. So one of my professors taught us this when I was in school, is a really great way to learn is to teach. So maybe you have one of your NICU BFFs and you want to teach each other, and you're going to say, okay, I'm going to teach you about gastroschisis. And when you have to teach someone something, you really have to have a deeper understanding, because you're kind of thinking ahead of what questions might they have about this disease process. So whether it's, your friend in the NICU, or if you get students in the NICU, or even your cat, or whatever you want to do, just talking it out and thinking about, okay, this is what gastroschisis is. This is where it usually is located. This is what it looks like. This is our management in the delivery room. These are complications I can anticipate. So that way you're thinking it through and you're using a different part of your brain compared to just reading about it or just listening to somebody talk about it. Another great way is to create flashcards. So that's kind of 2 dimensions. You're creating it, writing it out is really kind of helping you seal it in your brain, but also that quizzing yourself. It will help that short and long-term memory. Another really important piece is that understandably, cramming is not going to work. So the little bits of knowledge and understanding over time, and then sleep is really important to make those connections in your brain. So you think about when we're taking care of our babies in the NICU, I don't know about you guys, but in my NICU, we talk a lot about how their brains are very neuroplastic and how we are creating connections in their brains. Well, when you're studying for the RNC, the same thing is happening with our brains. Our brains are also neuroplastic. And whether you're learning this concept for the very first time or you're strengthening that connection, it's making those connections in your brain. And that takes a lot of energy. And so you need to do it slowly over time. And so with that said, oops, on my next slide, you want to give your brain time to absorb. So crashing and studying for 6 hours the night before the exam, not the best way to make sure that you pass. Break up your studying into bits of time. So whether it's 45 minutes of study and 15 minutes of break, or 25 minutes of study and 5 minutes of break, give your brain a time to rest and a time to process. And then also, as best as you can, I know it's hard, especially if you work night shift, to sleep. Sleep is really an important part of that memory and learning. And that's when the short-term memory that you've learned gets transmitted to your long-term memory in your brain. So another super important piece. Also, we are so lucky because there's so many resources, really great resources that allow for different types of learning. So one of the biggest things as far as textbooks go, I always tell people is go to your hospital's medical library and see what neonatal textbooks are available. I'm always kind of surprised to see how many resources are available for free through your hospital medical library. So two of the big neonatal textbooks I recommend is the Core Curriculum for Neonatal Intensive Care and Merenstein and Gardner's Handbook of Neonatal Care. Those are both textbooks, so it's full of information. There's also question books that I have not seen are usually on those hospital library websites, but maybe your hospital does have it. Kim is saying in the chat that Elsevier also has a resource. So those are all great things. Also, if your hospital has Lippincott has specialty certification reviews with lots of practice questions. I know there's other ones, like if your hospital has the A1 NOEP module. NOEP is really a neonatal orientation guide, but all the concepts are very much directed towards the RNC-NIC and all the things you need to know as a specialty NICU nurse. And there's so many online resources too. So there's YouTube, watching videos from like Tala Talks and the NICU Doc and Lisa Houston. They all have wonderful things. On Etsy, there's a lot of great stuff. I know my friend, Nurse Kelly, she has these beautiful notes that she hand wrote that are excellent for the RNC-NIC. There's Instagram. So hopefully you guys know me, but if you don't, I have a lot of Instagram things that are great reviews for the RNC-NIC. And then there's also TikTok. I don't know TikTok quite as well, but there's a lot of creators and a lot of NICU nurses, NNPs, doctors that are on there and that they are teaching all these concepts. So there's a lot of different ways to learn and reinforce this material. I forgot to write it on here, but podcasts. I love the Incubator podcast. They always have really great things to talk about, really interesting, more research, maybe not so much for the neonatal nursing certification review, but very good. And then there's a lot of different review courses available too. I have one, Anne has one, Nan has one. I think there's Nurse Builders. There's a bunch of them. So there's lots of resources out there to help you get certified. I put this little QR code here, which is just, it's my ebook that I created that has links to a lot of different textbooks, the stable program, the stable cardiac program, these textbooks. So there's a lot of stuff out there to help us prepare. So you guys, it's really a great time to become certified. Now, moving on, one of the biggest barriers, one of the biggest mind blocks I know when I talk to a lot of nurses is test anxiety. Do any of you guys get test anxiety? Tell me in the chat if you get test anxiety. Talking to a lot of nurses, a lot of people have told me, like, I feel like I know this content, but I just feel so anxious. Definitely, yes. I know I get anxiety. I get test anxiety too. And so as a CNS, one of the first things I did was I went to the literature and I was like, okay, well, what is out there as ways we can manage our anxiety? Because you do know the content, but we have to find ways that we can manage anxiety. So I found some different papers and some systematic reviews that looked at for nursing students, not necessarily for neonatal nurses testing for the RNC-NIC, which is quite a niche, but nursing students. And these are some of the ones that I found really interesting. So they talked about aromatherapy hand massage. So in the paper, they talked about a lemon scent of aromatherapy, that citrus and hand massage, that really helped some people with their anxiety. Guided imagery. This is something that I find fascinating that a lot of athletes do, where it's actually like a mental rehearsal. So if you picture yourself going into that testing center and signing in and giving your ID, and you're sitting down at the computer and you're calm and you are confident, and you finish and you leave, and then you can imagine yourself the following Wednesday and you log into the NCC website and you see your first and your last name, comma, RNC-NIC. That guided imagery, that mental rehearsal is something that a lot of people do to improve their practice and improve the way that they can do things. So whether it's for testing or for athletes, it can be super helpful. Another one that I thought, of course, music therapy, hype yourself up. Is there a song that gets you going, makes you feel pumped, makes you feel like, yes, I'm ready. I know this. I do that just before I got on here with you guys, because I have anxiety to get to talk to all 30 of you. It's so exciting to me to listen to music and kind of be like, okay, I can do this, you know. Emotional freedom technique is something really interesting that I had never heard of. Have any of you guys heard of the emotional freedom technique? I'm going to take a sip really quick while you guys chat. So the emotional freedom technique is essentially tapping. And so you kind of say out, like, I know that I am having anxiety about this test, and you're tapping on certain areas of your body. And the systematic review that I read, it was saying that this emotional freedom technique or tapping can have an effect of decreasing anxiety and making people feel calm. So it involves tapping on your wrist, tapping on your forehead, and your, like, around your sinuses, around your nose, above your lip, on your chin. Somebody is not muted, so if I can find you, I'm going to unmute you. Or if you could mute yourself, that would be great. But so thank you. It involves just tapping, and that is supposed to help you relieve anxiety. Bree is sharing. Mel Robbins' narrative is to repeat how excited you are instead of feeling anxious, to change that feeling. Yes, I love Mel Robbins. I love listening to her podcast. Absolutely. That's another one I have learned is talking about the feeling of anxiety is very similar to the feeling of excitement in your brain. And so telling yourself, I'm so excited for this exam. I'm so excited to get my RNC-NIC. I'm so excited to hear about when I pass. So all of these, just the way that we talk to ourselves is really important, and it's really going to make a difference in that anxiety that we have and in our success. Another one that was in that systematic review talked about diaphragmatic breathing. So taking deep breaths, and specifically, I can't remember the specific term for it, but when you count to 4 for your breathing, you hold for 4, and then you exhale for 4 seconds. And then you wait for 4 seconds. So I kind of think of it like a box. And understandably, as nurses, we know that this deep diaphragmatic breathing, it's going to control our vagal nerve. It's going to lower our blood pressure. It's going to make us feel calmer. So all of these are some strategies that we can use for anxiety. I'm a big believer in the way you start your day and your daily habits. So I'm a fan of listening to guided meditations. I use Headspace every day. I wanted just to share this QR code if you wanted to try it for 30 days for free. Here it is. But I like listening to that. I like the guy's voice. It can be anywhere from 2 minutes to 20 minutes and whatever works for you. But I think that can be really helpful just to start the day with that. Even if you're not necessarily, I can say I'm not always sitting just quietly listening to it. Sometimes I'm listening to it as I'm getting ready in the morning, but it's just kind of setting your mindset for that day, that everything is going to be good. You're going to have a good day. Another thing that I like to use personally when I'm having anxiety is grounding techniques. So when you're sitting and you are feeling your feet on the floor, you're feeling your sit bone in the seat. This is something you could also do during the test. If you're just like, oh my gosh, I'm so overwhelmed, just take a moment, pause, focus your attention to your feet on the floor, your sit bone in the seat, your hands in your lap, your breathing, just to pause the anxiety and the overwhelming emotion in your brain, and just to focus on what is happening right now, the present. I think that can be super helpful. That helps me when I'm having anxiety. Bree sharing in the chat that also the Insight Timer has a ton also of guided meditation, I think. Thank you guys for sharing with each other in the chat. I love it. But one of the big things I want to say, just if you're here, know that you are prepared. Like, I thank you guys for being here. It makes me think of Mel Robbins, and just being here and just taking the step towards professing accelerating your professional practice, is showing that you are going to be prepared. You know this, and you are smart. You have this, and you're going to do well. And one of the big things too is that one test does not define your worth as a nurse. It's one test on one day. And I just love that they're doing the second chance free promotion, because that takes away that big mental block of, what if I don't pass? What if you don't? Then you don't. Then you can take it again. It's okay. It doesn't mean that you're not a good NICU nurse. Another great learning strategy that I like is studying with a group, having your community where you can talk to each other and talk ideas out together and challenge difficult concepts together. I find that just listening to different people and the way they explain things can help make things make sense in a different way. So I know I couldn't have gotten through nursing school without my study group. And I have some exciting news about an upcoming study group that I'll talk about later in our talk today. But does anybody have any questions so far before we get into, we're going to practice some test questions together? I love all the things that you guys have been saying in the chat. All right, so let's practice some questions together. So I'm going to put up a question, and I'm going to give you about 30 seconds to a minute to answer your answer. You can put it in the chat. You can write it on a piece of paper, whatever you're comfortable with, and then we'll break it down together. Okay, we're going to do the test taking tips. So question number 1, a nurse suspects which of the following cardiac defects in an infant with congestive heart failure, cyanosis, and pulmonary edema, or the snowman appearance on chest x-ray? So A, AV canal defect, B, tetralogy of Fallot, or C, total anomalous pulmonary venous return. So take a guess. If you want to be brave, you can put your guess in the chat. Okay, so let's break down this question together. So when I'm reading this question, I'm thinking to myself, all right, this is an infant with congestive heart failure, cyanosis, pulmonary edema, and a snowman appearance on chest x-ray. Has anybody heard of the snowman appearance on chest x-ray before? So first thing I would kind of think to myself is, which of these of my options, which of these can cause congestive heart failure? So there's the AV canal defect. Can that cause congestive heart failure? Yes. the tetralogy of Fallot, does that cause congestive heart failure? I'm thinking not so much, really. Tetralogy of Fallot, the big thing, those 4 defects. One of the ones that is the most instrumental about whether this is a blue TET or a pink TET is the right ventricular outflow tract obstruction. So even with that VSD, we don't get that pulmonary overcirculation. We don't get all that stress on the heart. So we don't see as much congestive heart failure. So I wouldn't say B. C, total anomalous pulmonary venous return. Can we get congestive heart failure? Yes. So we'll just knock away tetralogy of Fallot. That's not it. Now we're down to 2. Okay, so which of these can have a snowman appearance on chest x-ray? I know some of you guys said, yes, you've heard of snowman appearance. Some of you guys have said no. So what is this? So it is TAPVR. So good job for you guys in the chat. I saw a lot of C's, so awesome. What is TAPVR? So TAPVR is a rare congenital heart defect, cyanotic congenital heart defect, where the pulmonary veins drain abnormally into a different location. So normally you have those 4 pulmonary veins that would drain into the left atrium, right? In TAPVR, they are draining somewhere else. So in this picture, I think it's from the CDC, they are draining up into the SVC. And you can kind of see, I don't know if you guys can see my mouse or not, but you can kind of see how this abnormal vein kind of creates this circle above, and then we have the heart below. So we'll see on an x-ray how you see that snowman. But there's 3 types of TAPVR. So supracardiac, that is the one that we were just looking at, where the abnormal vein or the anomalous vein drains into the supraventricular, or into the SVC. We have the cardiac, which we have the veins abnormally drain into the right atrium. And then we have the infracardiac, where it's the vein is abnormally draining below the diaphragm down there in the portal venous system. And we can also have mixed types of TAPVR. So I've seen babies where it's like maybe they have 2 veins that are draining normally into the left atrium and 2 draining into the infracardiac. You know, it can vary. So what might we see if we're the nurse taking care of this baby? So our clinical manifestations can range. We can have babies with, if it's a non-obstructed TAPVR, they will start to have congestive heart failure because there's so much blood flow to the right side of the heart. The right side is having to really work hard to pump the blood to the lungs as well as to the systemic side. We can see increased pulmonary markings because of that overcirculation and that snowman appearance on chest x-ray. If the TAPVR becomes obstructed, that's a surgical emergency. This baby is going to be profoundly cyanotic, and it doesn't matter how much support we're giving from the ventilator, we will not be able to cross it because it's obstructed. There's no blood flow getting to the lungs. So these babies may require ECMO. Understandably, with this cyanotic lesion, these babies would need mechanical ventilation, inotropic support, and PGE to keep the ductus arteriosus open. So test taking tips for this one: make sure that we are reading the question thoroughly. Use your process of elimination to remove the wrong answers. And if you're not sure about an answer and you're doing the RNC-NIC, flag it and come back to it later. Something might spark your memory later in the test, but like I said, you only get those points for the questions that you get right. You're not penalized for questions you get wrong. So if you came up to it and you're like, I really don't know if it's AV canal or if it's TAPVR, I'm going to guess, and you've already knocked out one, so you kind of have a 50-50 chance here. Now, I was talking about the snowman. Have you guys heard of some of these different radiologic findings for congenital heart diseases? There's the boot-shaped heart. I think that one is more familiar. The egg on the string, the snowman, and the box-shaped heart. Have you guys heard of some of these or any of these? Not very familiar. Okay, good. I hope that's why I added it in here, because I was like, I feel like some people may or may not have. Yes, except for the box-shaped heart. Yeah, when I was doing the research, I was like, box-shaped is not what is in my head. We don't get a lot of cardiac kiddos. Yeah. Okay, great. So let's talk about these. So probably one of the more common ones that people know about is the boot-shaped heart. and that's tetralogy of Fallot. And do you guys remember what the 4 defects are for the tetralogy of Fallot? So it's our right ventricular hypertrophy, our right ventricular outflow tract obstruction, or pulmonary stenosis is much easier to say, our VSD, and our overriding aorta. And it's the RV hypertrophy that's causing this like boot-shaped appearance. So it's big in the right ventricle, then bigger than it normally would be, and that's why it causes that kind of boot. Egg on the string is transposition of the great arteries. So the transposed arteries kind of causes the right atrial border to be abnormally convex. It's almost like it turns, like the heart just looks much more narrow, like an egg. I have to say, a lot of these, I see them in test questions. I see them in textbooks. I don't always hear them in clinical practice, unless maybe I hear teaching like between the neo and a fellow or something like that, or the NNPs teaching the fellows. So I don't always see it. I don't know that I personally would have said that that looks like an egg on a string, but that is something that I see in test questions. So just good to know, egg on a string, transposition of the great arteries, just because of those transposed arteries. I don't know if you can hear it, but my kitty is out there yelling at me. He's upset that he's not sitting here with all of us. Okay, the box-shaped heart. So this one, I hadn't always heard of it as a box-shaped heart, but I have heard it as Epstein's anomaly, the biggest heart you've ever seen. So it's taking up almost the entire chest because of that tricuspid valve dysplasia and that right ventricular problems. So biggest heart you've ever seen is Epstein's anomaly. So anytime you see an x-ray like this, where it's like, oh my gosh, that heart is taking up the entire chest, it's like we right away think Epstein's. And then lastly, the snowman appearance, which we just talked about with our TAPVR. So that dilate and nominate vein connecting to the SVC kind of creates the top, the head of the snowman, and then the actual heart creating the bottom part. So that is our interesting different radiologic findings. All right, let's move on. Question number 2. Which of the following should the nurse do immediately after an instrumented vaginal delivery? A, assess for signs of trauma. B, apply an ice pack to the head. Or C, measure the head circumference. This one's quick. You guys are like, I know this. So if I'm looking at this one, I'm like, okay, paying attention to certain phrases. It says, what do we do immediately? And the other thing I'm thinking about is, what are the complications of an instrumented vaginal delivery? So what are complications I'm worried about for a vacuum delivery or for a forceps delivery? I'm worried about trauma, right, to the head. So would I assess for signs of trauma? Yeah, I would. Would I apply ice to the head? No. There's only one scenario that I can think where I would apply ice to the face, but this isn't it. Do you guys know what that would be? Type it in the chat if you do. If you don't worry, I will tell you, but I'm going to give you a minute to put it in the chat. Yay, good. SVT, exactly. So ice to the face, and it has to be like right in the middle, like really in there for SVT, because we're trying to induce that vagal response, right? Good job. Sorry, I diverted a little bit, but back to this question. And then measure the head circumference. So paying attention to the words in this, what would I do immediately after delivery? So imagining this baby just was born, is the first thing I'm going to do measure the head circumference? No, I'm going to assess. So always think, going back to the NCLEX, going back to nursing school, we're going to assess. That's our first part of our nursing process, right? Is assessment. So again, my test taking tips for this question is always reading the question thoroughly, eliminating obviously wrong answers, and paying attention to those keywords first, immediately, prioritize, anything like that. And like I said, our nursing process, thinking about that in this question. We're flying through these. Number 3, you're caring for a 34-week newborn with respiratory distress syndrome who's intubated on SIMV. The rate is 20/5. He received surfactant administration about an hour ago, and our blood gas is pH 7.46, CO2 is 24, and bicarbonate is 25. you call the NNP2 request? A decrease in the PEEP, a B, an increase in the rate, or C, to wean towards extubation? Yeah, so let's break this down. Let's break down this blood gas. So first thing we always want to do when we're looking at a blood gas is look at the pH. So is it normal? Is it abnormal? It's abnormal. It's abnormally high. So we know that this is an alkalotic blood gas. And then we're going to look at our bicarb and our CO2 and see which of those aligns with alkalosis. So our CO2 is very low. We know CO2 is an acid. So a low CO2 would align with alkalosis. Our bicarbonate is within normal range. So that is not contributing to this baby's alkalosis. So here we have an uncompensated respiratory alkalosis. So what causes uncompensated respiratory alkalosis? So oftentimes in the NICU, uncompensated respiratory alkalosis is iatrogenic. It's when we are overventilating a baby. So a baby on the ventilator, just like in this scenario, this is a baby who had RDS. We gave surfactant. I imagine a lot of you guys have seen when you give surfactant, their ability to breathe, their need for support rapidly goes down. And so from this baby needing even low settings, rate of 20/5, now they're overventilated. So what would we want to do? We'd want to wean. We'd wean our rate or wean our tidal volumes, our inspiratory pressure. So that is what is blowing off a lot of that CO2 and causing our pH to come up. So let's look at what our answers were again. So we could decrease the PEEP. And what does PEEP do? What does that control? So that's going to control our oxygenation. And really, we don't really need to adjust our oxygenation so much. Increase the rate we would not want to do because that would cause us to blow off more CO2. If we blow off more CO2, then our pH is going to go up and our CO2 is going to go down even more, which is really not good for our little sweet 34-weeker here. So that leaves us with C, wean towards extubation. So that is what we would want to do. We would expect that the NNP is going to order a wean towards extubation. So maybe just completely extubating, taking off the tube, putting the baby just on CPAP or something to support this baby and to normalize this blood gas. Good job, guys. So for this one, again, always one of my first test taking tips is make sure you read the question very thoroughly. Don't jump to what you think the answer is going to be before you finish reading the question because you just might miss something. So we don't want to miss anything. If anytime it's a question with a blood gas, just write it down, interpret the blood gas before you even go to the answer choices. Just understand what it is that you're dealing with here. So in this scenario, we were dealing with an uncompensated respiratory alkalosis. And respiratory alkalosis in the NICU oftentimes is because our babies are overventilated. We need to wean that ventilator. Then again, eliminate any obviously wrong answers. So if we know that this baby has respiratory alkalosis, and that's because of overventilation, then increasing settings on the ventilator is not going to be correct. So we can just throw that one out. And then another one of my biggest tips always for blood gases, because I find just talking to people that blood gases is a challenge for a lot of us. Talk to your RTs, talk to your NNPs, talk to your NEOs, ask them about why they're making the changes they're making on the vent when you're taking care of those babies. Try and understand it at that deeper level, and that will help you as you're preparing for your exam. All right, question number 4. You're caring for a growing X27-weeker who's now 32 weeks corrected. She's on a full enteral feeds, and which of the following diets would provide optimal weight gain for her? She weighs 1,500 grams. So would it be 20 mLs Q3 of 27 kcal breast milk, 30 mLs Q3 of 24 kcal breast milk, or 40 mLs of Q3 22 kcal breast milk? I don't know about you guys, but I look at that and I'm like, wow, that's a lot of numbers. So the first thing I would do approaching this is what is normal and how much total fluids is each of these giving me? So let's first figure out for each of these volumes, how much ml per kilo per day is this giving me? So with our weight and each of those volumes, we would calculate. So take the volume Q3, we multiply it by 8, right? To get the total volume per day. And then divide that by the baby's weight to get our mLs per kilo per day. So for our baby getting 20 mLs Q3, if they're 1,500 grams, that only gives them 106.7 ml per kilo per day. So is that what you would expect for a baby to be able to grow? No, right? It's a little low. And then so for B, 30 times 8 is 240 and divided by 1.5, that gives us 160 ml per kilo per day. Is that what you would probably expect? Yeah, that seems more reasonable. And then C, 40 gives us 320 mLs a day divided by the weight is 213 ml per kilo per day. It's kind of a lot of fluid. Do you typically see the total fluids that high? So just based on the total fluids alone, we could probably eliminate some of these answers. So just a reminder, when you look at the literature, what is the total fluids preemies need for growth? And it's, there's a wide range because of the different needs of our premature babies, but anywhere from 135 to 200. But what I see most frequently is about 140 to 160 ml per kilo per day. But, depending on the need, they may need more. And then total kcals, 110 to 135 typically. So just with those, looking at our total fluids, we are able to eliminate 2 of the 3 answers. So that's awesome, right? That just leaves us the one at 160 ml per kilo per day. But for fun, let's also figure out how many kcals each of these is giving and see how those equate, which of those make sense. So to determine your kcals, you have to see how many kcals per ml each of these offers. So all we have to do basically is divide that by 30. So our 27 kcal per ounce is 27 kcals and 30 mLs. So that gives us 0.9 kcal per ml. Similarly, for 24 and 30 is 0.8 kcal per ml, 22, 0.73 kcal per ml. So taking those, we just multiply that by the total fluids that we just figured out. So for A, we had 106.7 ml per kilo per day times 27 kcal per ounce. So 106.7 times 0.9, because that's how many kcals are per ml. And that gives us 95 kcals per kilo per day. So is that within that range? It's a little low still. Our B number 160. So for 24 kcals, that's 0.8 kcal per ml. So 160 times 0.8 is 128 kcals per kilo per day. That's more within our range. And C, for our 22 kcal baby, so 22 divided by 30 gives us 0.73, and 213.3 times 0.73 gives us 156 kcal per kilo per day. So that would be a lot of fluid and a lot of calories too. So just for both of them, we have our answer. It's B. So good job, guys. You guys all got that really fast. And again, feel free if you guys have questions. For this one, test taking tip, if you see something and you're just kind of like, wow, that's a lot of numbers, don't panic. Just break it down. This is stuff that you guys probably do every single day in your shift, talking about total fluids, calculating volumes. You do this all the time. So don't get overwhelmed by it. So just take it one step at a time, find out your total fluids and see, does it match what you would expect for a baby that size? When you're taking care of babies in the NICU, if you have a 1,500 gram baby, do you expect them to only getting 20 cc's Q3 and no IV fluids? That seems low, right? So kind of think about it in that way and then eliminate your obviously wrong answers. All right. Can you skip questions and come back? Yeah, absolutely. So you can flag it in the test and you can come back to it later. So if you're looking at it and you're just like, I need to move on. I can't break this down right now. Flag it, keep going. And then once you finish, you go back to the ones that you flagged. Absolutely. All right, question number 5. Thermoregulation is super important for us to know as NICU nurses. As we all know, it's huge for our babies and for their well-being. So number 5. Heat dissipation from an infant to a cold object in the environment describes what type of heat loss? So is it conductive, is it convective, or is it radiant heat loss? So let's review all these different types of heat loss, okay? So our methods of heat loss. So first is conductive. So conduction, I always think about that D in conductive equals direct contact. So that's when you go to the doctor and they put the cold stethoscope on you and you go, whew, that stethoscope is stealing your heat directly. You put a baby on a scale and there's nothing to protect that baby from the cold. It's going to steal its heat directly. If you have really cold hands like I do and you touch that baby, you are stealing their heat directly through conductive heat loss. So think conductive with a D equals direct contact. Then we have convective with a V. So you can think of air currents or ventilation. So convective heat loss is if you're hot, oops, sorry, I hit my mic. If you're hot and you have a fan for yourself, you're trying to decrease heat from convective heat loss. When we're resuscitating babies in the delivery room, we want to have the side rails up to protect that baby from convective heat loss, from air currents hitting the baby. So I thought V, ventilation, air currents, however it can make sense to you, but convective is those air currents or that ventilation that's happening in the room. And then evaporative, I think all of us have probably experienced this if you've gone swimming, even on the most beautiful hot day and you get out of the water, it's like, oh, kind of cold for a second because all that water on you is turning into vapor. So it's evaporating and it's taking your heat with it. So evaporative, water or moisture turning into vapor. And of course, we can think about our babies when they're first born, they're covered in amniotic fluid. They have a lot of heat loss there. When we give baths, they have a lot of heat loss there. So evaporative is that water or moisture turning into vapor, stealing the heat. And then lastly is radiant. So radiant is that heat loss or gain by an object that is not in direct contact with that person or that baby. So for us, you could think about if you're sitting in a classroom next to a window and it's a hot sunny day and you're hot, even though you're not outside in the sun, but you're feeling that heat from the window, that's radiant heat gain. Or vice versa, if it's a really cold day outside and it's snowing, I know a lot of you guys, you're in Nebraska and Pennsylvania and places that I think of that it probably gets really cold in the winter. If you're sitting next to the window, it's snowing outside, even though you're inside, just being directly next to that window, you're losing heat to that cold that is outside indirectly without even touching it. So radiant is heat loss or gain by an object not in direct contact. So our beds have double walls to protect our babies from radiant heat loss, because if there's only the single wall, they can lose heat from the temperature in the room or being next to a window, things like that. So that's radiant heat loss. So with that, we have heat dissipation from an infant to a cold object in the environment. So making sure that we are paying close attention to how it's phrased in the question. So not in direct contact with the baby, but in the environment is radiant heat loss. So again, always make sure you read the question really carefully, review what you know, write down what, if you need to, how you know these different concepts, and eliminate your wrong answers. You can do it. I'm so excited for you guys to get your RNC. This is your year. This is going to happen. And I'm really excited to announce that I am starting a virtual study group. So a lot like these last 5 questions that we just did, this would be an opportunity for us to together as a team, as a community, kind of talk through these difficult concepts as you're preparing for the RNC-NIC. When I found out about the second chance free promotion, I was like, oh, I just have to do something for everybody. I want to help you guys. So I would be facilitating these on these different days via Zoom, just like we are today. It's $97, and with that, you get access to all of this, the recordings, a course platform, extra test questions, a community access to a private Facebook group where we can all chat together and ask each other questions at any time. Q&A submissions. I have a form where you can submit questions, and I really hope that you do so that I can create questions based off specific topics that you're struggling with. So if it's blood gases, if it's cardiac, if it's renal, if it's endocrine or all of the things, you know, that way we can practice these together. And I created this really to complement the certification success course that I have. So you can bundle them and save and get it for a little bit of a discount as well. But some of the questions I've gotten already about this, I'm real excited. It's going to be on these dates. Oh, where'd it go? These dates at 9 o'clock in the morning on Zoom. They will be recorded. The recordings will be uploaded to the course website. What other questions did I get? I said 9 o'clock in the morning. And really, it's intended to be a supplement and to help you with your studying. So with whatever you're doing, whether you like to review the textbooks and take notes, this will be a supplement where we can work together, work through the difficult concepts. Feel free to send me any questions you have in the chat. Oh yeah, what time will it be offered? 9 a.m. Pacific. And I'm planning for it to be around 90 minutes to 2 hours. It just depends on how much discussion we all have together. So I wanted to offer it to all of you guys. I'm so happy that you're here. I want you to succeed. And regardless, I hope this webinar was helpful for you to break down some of these test questions and to kind of think about it in a systematic way, hopefully to address any feelings of anxiety, give you some tools in your toolbox to help you succeed. But I really hope that you guys, when you do get certified, that you DM me on Instagram or you email me, because I want to celebrate you. And as you know, I just love certification. I think it's great. It's a great way for us to continue our professional practice and demonstrate our knowledge and our expertise as NICU nurses. Now, what questions do you guys have for me? Because that's the end of my presentation. These are my references. I'm going to send you guys these slides. After this, you'll get an email from me with the slide information, with the study group information, with all of it. Are you guys excited to get certified? I hope you are. I'm excited for you. Can you see it? Can you see your name and then RNC-NIC after? I can. Yes, yes. If you can't make it to a class, absolutely, you can rewatch. Yeah. So it would be on the platform. You can rewatch it as many times as you want. You can submit questions. And even if you can't be there, I can address those questions. And so you can look at the recordings. Definitely you can. You're very welcome. I hope these tips helped you. And I hope you learned something, you take something away about the test formatting, about addressing anxiety, about tackling these test questions. You guys are awesome. I'm so happy that you're here. Okay, well, if you don't have any other questions, then I will see you later. Feel free at any time, reach out to me on Instagram. You can email me. I'd love to help you guys. Thank you all. Have a wonderful rest of your day. Happy Thursday or happy whatever day it is if you're watching the recording. And I will see you all later.